A pleasant morning to everyone. Today is another great day in our obstetric unit because today begins our quality improvement plan on immediate newborn care management. As the hospital strives to become the hospital of choice in Queens, we, the obstetric unit, strives to make this unit the safest, most efficient, pleasurable, and edifying unit for both staff and patients. Let me take this opportunity to applaud all the professionals who work tirelessly to ensure the safe care of the mother and baby during delivery and beyond. A special welcome to everyone, our Chief Executive Officer, our Chief Nursing Officer, Chief Financial Officer, our Quality Improvement Team, fellow doctors, nurses, legislators, and all our valued stakeholders. Today, we will take a look at the background and the impact of the current management of newborns and discuss the quality improvement measures we can implement to improve the care and outcome of our infants. One would ask, why is the immediate care of newborns so critical to their health? Let's look at it. The initial management of newborn plays a vital role in determining their health. World Health Organization reports that 25 to 50% of the 3.1 million newborn deaths in 2010 occurred in the first 24 hours. And Oakland states that approximately 10 to 15% of babies are admitted to the neonatal intensive care unit for special care in the USA. According to CHIA in 2019, the financial expenditure varies according to gestational age and patient condition. However, the average cost of care ranges from $1,000 for term infants to $9,100 for extremely preterm infants. This makes us wonder, what is the cause? And what is the solution? While causes vary from genetics, maternal disease, intranatal and perinatal complication, World Health Organization in 2018 reports that simple interventions such as drying, cord clamping, skin-to-skin contact, and breastfeeding initiation performed by skilled healthcare attendants could decrease the number of infants requiring special care or those dying. Let's come closer home and look at our own unit. Impressively, we have had no deaths within the first 24 hours since 2018. However, our admission rate to the neonatal intensive care unit is significantly higher than the nation's average rate, which is 10 to 15%. Let's look at the statistics. In 2018, 1,628 babies were delivered, of which 30%, 488 newborns, were admitted to the NICU. In 2019, out of 1,378 deliveries, 31 infants, or 31%, which is 426 infants, were admitted. Let's go to 2020. Although deliveries decreased to 1,076, we still had a 41%, which is 439 newborns being admitted to the NICU. Financially, the average cost of care ranges from $2,200 to $3,700 per infant stay. The increased neonatal intensive care unit admission rate suggests there is a need for assessment and intervention, and this is why we're all here today. Although the newborn health depends on many factors, immediate care after birth have proven to be most effective. We have emailed you several studies showing that simple but effective interventions immediately following delivery have improved the outcome of preterm and term infants. It decreases morbidities such as hypothermia, hypoglycemia, and reduce newborn stress hormones. Newborn care is vital for a successful transition. It decreases admission to the neonatal unit. It improves long-term and short-term care. It decreases financial burden, and it decreases our workload. Let's take a look at the many negative impacts of unsuccessful transition. As we saw before, it increased newborn admission rates. It affects newborns' short-term and long-term health. It disrupts the bonding process of parents and infants and also interrupts breastfeeding. It affects the physical and psychological health of parents. It increases practitioners' workload. And, of course, it increases the financial burden on the hospital itself, the insurance companies, government, and the society at large. Which leads us right back to our happy baby. Our statistics, the evidence-based practice that we researched, and our compulsion to provide the highest level of patient care have identified and prompted the need for this quality improvement project to improve the post-delivery management of our newborns. Let me explain our quality improvement project proposal. It involves a threefold plan to 1. Provide all necessary resources. 2. Make sure that all staff are competent in resuscitative care. And 3. Educating mothers of the expected initial care of their newborn. All three aspects of the plan will be conducted simultaneously. Staff education. While I'm aware that majority of our staff are NRP certified, there is a small percentage that are not certified. It is our goal that all professionals involved in infant care will be certified by October 2021. The hospital will pay for the course and employ an NRP educator to facilitate neonatal resuscitation technical skills learning. The Reliance program for continued education is already in place, but let's be honest, majority of us don't even look at it. Now, it will be a monthly requirement of all staff. The nurse manager will actually be required to monitor for adherence. Staff education meetings will be held on all shifts to provide knowledge and discuss evidence-based practices. Lastly, but very important, we will conduct post-delivery care simulation. Simulations are very good because it helps the practitioners to practice their skills and to build confidence. We will be keeping these simulations at least once monthly. It will include the basic resuscitative straight up to the advanced resuscitative care. It will be done on all shifts, and all staff are required to register and engage in these simulations. The staff roles will be rotated to facilitate team bonding and for staff to appreciate each other's profession. Ongoing parental education will begin in the antenatal period and continue into the delivery and immediate postnatal period. Nurse educators will keep weekly sessions to educate the mothers of the beneficial best practices, such as immediate skin-to-skin bonding, breastfeeding, delayed cord clamping, and providing warmth. The rationale and the benefits of these measures will be highlighted to encourage adherence and cooperation from parents. Parents will be reminded of these measures during and post-delivery. As with all projects, we need human and material resources. Luckily, we already have some of these. The resources needed will include the NRP manual, the NRP educators or in-service educators, mannequins, computers, resuscitation equipment, money of course, the rooms, chairs, microphone, public announcement systems, monitors, and drugs. Based on your valued answers in the survey, we will begin this project in June 2021. While the implementation measures will be ongoing to facilitate repetitious learning and culture change, the initial timeline spans from June to December 21 for the complete implementation of the project. NRP classes will be kept every first Wednesday of the month. NRP online courses are available 24 hours per day. In addition, we'll have weekly staff education session on all 3 shifts from June to September, followed by a bi-weekly meeting from September to December to provide staff support. Relias will be online 24/7 for the entire time. Simulation exercises will be held once monthly on all 3 shifts starting in June and continuing until December 21 and beyond. Parental education will be kept twice weekly from 8 a.m. to 9 a.m. from June 2021 onwards. These classes will inform parents of best practices within the immediate post-delivery period. Parents will be allowed to ask questions, clarify misconceptions, and understand the rationale for the implementations. The hospital will use available resources such as computers, chairs, screens, monitor, and staff. Additional resources will be purchased within the first 2 months to facilitate learning and provision of adequate resources. While there will be continued assessment and adjustment, the initial evaluation will begin in December 2021. The outcomes will be measured by the percentage of staff that are NRP certified. Staff competence will be evaluated by the simulation team and also by a staff survey. We hope to see notable improvement in the intrauterine to neonatal transition, and this will be measured by the APGAR score. Neonatal intensive care unit admission rates will be reduced, as well as the mortality and the morbidity rates will also be reduced. The overall goal is to have a 20% decrease in the neonatal intensive care unit admission rate by December 2021, following advanced training of the staff, education of the parents, and provision of adequate resources. We can all agree that the benefits of this quality improvement project are too much to ignore. While we provide excellent service, it is impressive that simple, evidence-based interventions can promote health, reduce costs, decrease morbidities and mortalities, and literally change the world. The project plan includes certification and training of all staff, ensuring all equipment are functional, providing needed resources, and educating our parents. Moving forward, we will have monthly meetings, webinars, and emails that will be used to communicate our plans, the barriers encountered, and of course, our progress. We invite all our stakeholders to join minds, hearts, hands, resources, and finances to enhance the nation's health and the nation's wealth. I thank you.